morning, everybody. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And so with that, I'm delighted to introduce Dr. Rob Pauly, who received his MD at the University of British Columbia, his nephrology and master's in epidemiology at McGill, and a research fellowship at the University of Toronto. He's been a faculty member at the U of A since 2007. He has an active research portfolio focused on the care delivery of home-based dialysis modalities in 2019. In 2019, he was named Assistant Dean, Faculty Wellbeing for the Faculty of Medicine and Dentistry at the University of Alberta. And today he's going to talk about the electronic health record, the thing we love to hate and what it means for clinician well-being. So over to you, Rob.
Great. So thank you very much. This is, very clearly a deviation from my usual dialysis-related talk. So I'm hoping that I won't disappoint. So thank you very much for having me give this presentation today. And let me start by, putting this up here, why doctors hate their computers. Digitalization promises to make medical care easier and more efficient, but are screens coming between doctors and patients? And this was a really nice piece written by Atul Gawande in the New Yorker in 2018, and is something that, many people in the audience will have certainly read. And he comes to the conclusion somewhere in his writing that, 3 years later, I've come to feel that a system that promised to increase my mastery over my work has instead increased my work's mastery over me. And perhaps this is a sentiment that is shared by several in the audience. This was followed a year later by sort of this other very splashy publication in Fortune magazine, Death by 1,000 Clicks. Sounds very dramatic. Where electronic health records went wrong. And then it sort of outlines, all the various things that have happened along the way, particularly in the US healthcare system with respect to the electronic health record. So an interesting read, but, quite dramatic, I would say. With that sort of as a bit of a background and as a frame, I should, confess I don't have any disclosures with respect to this topic. Let me walk you through the outline of what I hope to achieve today. Firstly, I'd like to describe the historical context of electronic health records spread and scale. I'll be using EHR, that acronym for electronic health records, so we'll have to get used to that. Describe how electronic health records impact the care delivery system, so kind of the operationalization of care, and explore the relationship between the EHR and clinician well-being in as far as there is literature around that topic. And so I hope you'll indulge me over the next 55 minutes or so as we explore these topics. So let's begin by looking at the historical context of EHR spread and scale. And I'd like to frame this part of the talk, around this Institute of Medicine 1999 publication, To Err is Human, which reported that between about 50,000 and 100,000 patients per year die in US hospitals due to preventable causes, largely through iatrogenesis. And this is where sort of this often quoted aphorism, a jumbo jet a day, kind of refers to, the number of people who, potentially die every day in hospitals. And, this is clearly felt to be, or was at the time, sort of a very important, sort of piece of information that in some ways galvanized the medical community. And you can see here that between 1999 and 2005, so kind of in the sort of half decade after the publication of that Institute of Medicine report, both in the academic literature, but also in the lay press, there was a significant increase in the amount of writing around sort of iatrogenesis and hospital-based deaths. And then continuing along with the aviation theme was this book in 2008, Why Hospitals Should Fly, the Ultimate Flight Plan to Patient Safety and Quality of Care, that captured perhaps a little bit more of the public imagination of what care in a hospital could and perhaps should look like. And this happened in and around the time in 2008 where the Institute for Healthcare Improvement kind of culminated in sort of defining the triple aim. That is the three dimensions of performance of a healthcare system that we're all sort of relatively familiar with. That is to improve the health of the population, to enhance the experience of the care that is, experienced by the patient, and to do all that at a lower cost per capita. So, this in many ways is sort of the era in which the start of the QI movement really took root. And it was widely believed that electronic health records could help fix these complex problems of iatrogenesis and performance. But of course, 2008 should also kind of ring a bell for a whole variety of other reasons, because that, of course, is the start of the Great Recession. And, we can all sort of remember that, unemployment numbers rose dramatically. The month over month layoff numbers were, astronomical here. Just in February 2009, you can see there's over 300,000 unemployed. Over 3 million American households went into some sort of foreclosure. And into the White House rolled a, green new president, Barack Obama, who in December 2008 said, "We will make sure that every doctor's office and hospital in the country is using cutting-edge technology and electronic medical records so that we can cut the red tape, prevent medical mistakes, and help save billions of dollars each year." And with that, of course, came in February 2009, the very famous American Recovery and Reinvestment Act, whereby almost $800 billion of US federal government stimulus spending went ostensibly to save existing jobs, create new ones, support temporary relief programs, and ostensibly prevent the collapse of the entire US economy over and above what had already happened. Now, the key pillars of this act were investments in infrastructure, education, renewable energy, remember those sorts of things, but also in healthcare. And the healthcare component alone consisted of about $155 billion worth of spending. Now, the biggest portion of that healthcare spending went to support Medicaid. I don't think anyone's really surprised by that. But in fact, the second biggest proportion, to the tune of around $25 billion, went to healthcare information technology that was governed by this sub-act called the Health Information Technology for Electronic and Clinical Health Act. So a bit of a mouthful there, but ultimately called the HITECH Act. And the idea here is that there would be massive uptake of the electronic health record. In 2008, when a new president needed to look like he was doing something, electronic health records seemed like they were kind of shovel-ready concepts. Now, electronic health records weren't new in 2008. The only problem was that no one was really putting large, buckets of money into the endeavor. And the systems that did exist, at least in the United States, which is where this push really came from, by and large were serving billing and administrative purposes and not really clinical roles. So then we come to, of course, sort of this opportunity of the HITECH rollout. And the federal government had this desire of portability of healthcare information so that, you could take your kind of healthcare card or healthcare fob or whatever, and you could basically take it around anywhere. And that was kind of the idea. And of course, that was coupled to the idea that, in the early part of the Great Recession, stuff needed to happen quickly. And so there was an 18-month time frame for rollout that was sort of mandated to go along with that. And so, from the federal government's perspective, this resulted in something called meaningful use criteria, or a set of criteria that would need to be filled by vendors and providers in order to qualify for subsidies and incentives. And massive incentives to industry, hospitals, and even individual physicians were definitely on the take. And you can see here sort of in this little advertisement that if, you had showed up at the Indianapolis Hilton on, February the 10th, 2010, you could learn about your $44,000 plus worth of incentives if you were an uptaker of an electronic health record. So industry, for their part, clearly saw this as sort of this rare one-time opportunity to cash in on this federal program. And so they spent a lot of their time pivoting to gaining market share as opposed to creating products that were, made for purpose, with the purported attitude that, what, like, let's get market share, we'll fix this stuff later. And so, the interoperability, while perhaps idealistic from a policy perspective, was never really a logical incentive from the perspective of industry. And so, you can imagine that industry had this competitive invested financial interest to, kind of keep things proprietary and to sort of abort the whole concept of portability, which had been the purpose of the federal government. So it's critical to understand here is that the environment in which most contemporary electronic health records were built, including to a large extent the massive EHR that we're using in the province of Alberta, were sort of created and gained their chops, as it were, in this era of, like, let's just get out there and do what we need to do and worry about fixing the systems later. These systems were rarely built from the ground up as systems for primary clinical use, and I think that's really important. So let's turn our attention now to how the electronic health record impacts the care delivery system. And so I want to spend just a very cursory amount of time talking about what, you might assume a large portion of this talk would be about, and that is that how electronic health systems affect quality of care, safety, and efficiency of care. But I actually want to really just kind of pay lip service to that, because that could take an entire hour to talk about, and I'm probably not the right person to do that. I just want to summarize that by relying on this review that was published a year ago or a year and a half ago that basically tried to summarize some of these results. And clearly the electronic health record has been really positive for a number of different elements, not surprisingly decreasing, whoopsie daisies, what am I doing here? Not surprisingly decreasing care costs, reimbursement and revenue, especially from US-based hospitals. For those systems that have patient portals, there is the sense of patient empowerment, data storage, lots of other things. But if we get back to the ideas from the previous slide, the safety, efficiency, and quality, well, the jury's actually a bit more out on some of those topics. So certainly when it comes to workload for clinicians, look, electronic health records by and large don't save anyone any workload, and the efficiency, the extent to which workload and efficiency overlap with one another is also sort of the jury's out. Communication amongst physicians tends to favor that there is an improvement, and the quality of care, depending on how quality of care is defined, also tends to say that there is improvement. But clearly there are trade-offs here, and I think that's going to be a major theme that will come out throughout the rest of this presentation. But I want to leave that area and instead turn our attention to these three elements, and that I would call the invasion of clinician time, the effect on the clinical interaction, and on a topic that I want to call sort of electronic microaggressions and the cognitive burden. And so let's delve into this a little bit more. The studies that I'm going to show you over the next sort of 5 or 6 slides are really some of the landmark studies that were done in this area, and that actually were done sort of at a fairly high quality. And because, these are kind of statistics that get bandied around a lot, I think it's probably worth just showing you these. The first of these is entitled The Allocation of Physician Time in Ambulatory Practice, a Time and Motion Study in 4 Specialties. And this involved 16 practices in a diverse clinical setting, principally primary care, but also cardiology and orthopedics. And this was conducted kind of in 2 parts. One was a direct observation component using this kind of special work observation methodology. So really, really highly worked out methodology for doing this, where they trained a bunch of observers in a really specialized way. I'm going to come back to that in a moment. And then the second part was the self-reported diary of after-hours work over 7 consecutive days amongst these clinicians. And so, look, this is a super busy slide. I don't want you to pay attention to the details. That's not what's important here. The point is, there are a lot of details. This is what people were in the time and motion component were reviewing and were charting, all the way down to stuff like whether clinicians were taking a pee break, whether they were eating a snack or doing, telephone calls, and all of those things were recorded in sort of, a huge amount of detail, let alone all the different things related to clinical care and administrative tasks. And the upshot is really kind of summarized in this slide as suggesting that 33, so about a third of the time, was spent in direct clinical care, and about half the time was done in using the electronic health record. Now it says here desk work. That's because one practice was not using an EHR. But so ostensibly this is a electronic health record statistic. And this is where that often quoted statistic comes from when people say for each 1 hour of direct clinical face time, there is an additional 1.5 hours of electronic health record time during the workday. This is sort of where that comes from. So I'd have to say, I mean, this is clearly a fairly elaborately done study. Now, the second part, was self-reported after hours work in the day. And that amounted to about 1.5 hours outside of that kind of 8 to 6 window. And about 2/3 of that time was spent in the electronic health records. And so I think that's kind of an interesting statistic to keep in mind. Now, one of the other very famous studies that comes out of this kind of era is this one published in the Annals of Family Medicine in 2017, entitled Tethered to the EHR, Primary Care Physician Workload Assessment Using EHR Event Log Data and Time Motion Observations. And so this is looking at 142 family medicine physicians in Wisconsin using Epic system, so ostensibly the same system that we use. What's really important to understand here is that the EHR was implemented in 2018. So by the time they were doing this study, the clinicians were actually very comfortable using the system. And they use something called event logging, which I think is really cool. This is sort of an automated tracking feature within Epic, where like everything that we do within our electronic health record can get tracked. And there are over 1,000 different event descriptions that then these, investigators then categorize into sort of 15 broad groups. So anytime we move from any part of the electronic health record to a different part of the electronic health record, that's actually captured in this event logging thing. So, and not only that, it also captures whether that happens from your office, from a ward, from a home, or from wherever you might be. So this is sort of fairly high fidelity data. The second component of this study was a validation component. Again, that time and motion study looking at 14 physicians over a 6-week period. And again, fairly highly trained personnel for direct observation from 7 a.m. to 7 p.m. And again, lots of business on this slide, but this I just want to show you. This is the event logging categorization. So this is the details and the detail into which they went to actually capture, quality data. And this is, the time and motion component where people were, this is a screenshot actually of the recorders. And so they're recording, like whether someone was on a phone call, whether they were in their in basket, whether they were washing their hands, and, documenting that in a fair amount of detail. And so what you can see here is on the panel on the right is the number of minutes per day spent doing clerical work is about 2 hours. After hours is over a half an hour of time spent on clerical work. Now, in actual medical care, although I should qualify, this isn't the actual physical care of, people being like patients being examined. This is the part of the care where we're taking notes, where we're, reviewing medications, where we're charting. That was about an hour and a half cumulatively in a day, about 30 minutes of which was done after hours. And importantly, the amount of time that people spend within the inbox itself was about an hour during the day, about 20 minutes after hours. And so in its entirety, clinicians spent about 6 hours of their day within the electronic health record, about 4.5 hours of which was done during their clinic work time, and about 1.5 hours was done after what would be considered routine clinic times. And that amounts to about 30 additional hours per month within an electronic health record that falls outside of what most people would consider kind of, 8 to 6 working hours. Now, this is an important figure. What this shows is the percent of total EHR work time on the y-axis, and then the hours of the day on the x-axis. And you can see here, so if you look at the black line, so this represents, the amount of proportion of time that people spend in certain hours of the day during weekdays in the electronic health record. And not surprisingly, people engage during regular working hours. And the same thing over the weekends. If people are working on the weekends, they usually do so during the day. But this is the part that's kind of important, and this is why this paper receives a lot of attention, because these little shoulder periods at 9, 10, and 11 o'clock in the evening on weeknights, and the same thing happening on weekend nights, this is what's been dubbed as pajama time. So this is the time period that people are referring to when you're putting your kids to bed. You should otherwise be going to bed yourself, or maybe watching the news or reading the paper, but instead you're going back into the electronic health record in your pajamas, to tidy up from the day before. So that's sort of where that comes from. And the third study that I want to show you in this area is this one here: physicians' electronic inbox work patterns and factors associated with high inbox work duration. And the reason why I think this is of some importance is because the inbox and inbox management has received a fair bit of attention in this literature as being a particularly aggravating feature to clinicians. And so here, over 1,200 clinicians from the Kaiser Permanente group in 2018, were sort of investigated. Regular working hours were considered to be 8:30 to 5:30, and again, they used this Epic Systems event logging. Highlight here is that the data I'm going to show you is going to represent an underestimation of the actual amount of time in the inbox, because this analysis doesn't include the time that's spent moving between the inbox and the other components of the electronic health record that you have to access in order to sort of gather the information for you to respond to messages, etc. So you have to recognize that. But the upshot is that, about 20 minutes a day after hours is spent within inbox management alone, which is, again, highly consistent with the previous data that I've shown you. And this sort of study is, kind of shows you these really neat kind of graphics. These are all 1,200 patients up here. If you look cumulatively, that's them here. This is the duration in minutes. This is the hours during the day. So this is inbox management specifically. This is looking at the other electronic health function during the day more generally. You can sort of see people tend to take lunch at around 11:30 to 12:30. That's where this sort of dip corresponds to, during which time I'm assuming people are doing their inbox, because we don't have the same dip here. So interesting stuff. I think that helps kind of contextualize for each of us perhaps how we are doing ourselves as a bit of a benchmark. I want to next focus a little bit on the effect of the electronic health record on the clinical interaction that we have with our patients. And how I want to frame this is, look at what does it mean to do a consultation? So a clinical consultation kind of involves a few different things. So we have to sort of gather and record some historical information. You actually have to examine a patient, probably deliver some sort of diagnostic and prognostic news, provide some treatment recommendations, and educate the patient. Now, the extent to and sequence in which we do these things, of course, depends on the type of clinician that we are and the nature of that interaction. So are we a nurse, a dietitian, a physician? And of course, it depends on some personal factors, such as how organized we are. So the how these components of a clinical consultation are performed is actually quite critical. And the question is, in what ways does the introduction of an electronic health record affect the consultation process? And this, I think, is an area that's quite interesting. And I want to highlight kind of a couple of studies in this area, the first of which is this qualitative study rooted in grounded theory entitled Separating the Effects of Learning How to Use the EHR from Using It in a New Context. So what's important here is that all the clinicians that were involved in this study were already very familiar with the electronic health record, just not in the setting in which they were being asked to use it now, which is in an ambulatory care setting. And so they ultimately were able to define 4 facilitators and barriers to patient and clinician communication, sort of categorized broadly in terms of visit organization, verbal and nonverbal behavior, a clinician's navigation and mastery of their skills in that navigation, and the spatial orientation of the office relative to patient, computer, and clinician. And, in the interest of time, I'm going to skip over sort of some of the detail here, except to say that the overriding conclusion was that the computer itself, so this is not specific to an electronic health record per se, but just the presence of the computer that's required for an EHR. So that the overriding conclusion is that the computer did not improve any of these domains in individuals who were not good at these things to begin with. So if you were a disorganized mess, you were going to continue to be a disorganized mess during your consultation, even if you had an electronic health record. Though the computer may have enhanced elements of the consultation process in clinicians who were already proficient in these elements. So what's important here is that the conclusion of this sort of fairly detailed sort of study was that this wasn't a situation where a rising tide raises all boats. The boats that were going to rise, and the ones that were going to sink, were going to sink. And, this sort of is a really kind of a fun but somewhat tragic figure out of that paper with this attached quote. During this episode, lasting several minutes, the clinician's eyes never leave the computer screen. At one point, the patient attempts to see the computer screen by leaning out from the exam table, almost falls off, and then finally gives up. And then, of course, there's sort of the picture here on the right that shows kind of what that is actually supposed to look like. Now, there are a ton of studies that kind of look at this type of thing, including, something here where, people did these elaborate studies looking at eye gaze patterns of clinicians and patients as to who's making eye contact with whom at what frequency and at what rate, et cetera, which is sort of interesting. Or the influence of the actual spatial organization of where patients and clinicians sit relative to one another in the computer screen. So, the computer in the room, I think, ultimately changes the dynamic between the patient and the clinician, not often for the better. And this has implications for the deliberateness of how we orchestrate our interactions and our environments, and importantly, how we teach the next generation of clinicians how to do the same, especially when we ourselves aren't particularly good at some of these things ourselves, because we're still on a learning curve. Now, let me turn my attention, or our attention, to electronic microaggressions and the cognitive burden that may or may not be associated with electronic health records. And, somebody here has kind of done a bit of a cheeky study looking at the number of clicks, or kind of estimating the number of clicks in a 10-hour emergency shift, and suggesting that there are 4,000 clicks. And then somebody else did kind of an even cheekier analysis, I would say, of like, how much do those 4,000 clicks per shift cost the system? And, it's like it costs some astronomical amount. I mean, of course, this analysis is totally silly. I mean, you can't eliminate clicks. We were clicking before the electronic health records too. And we can't forget the fact that before we also had to document. So these sorts of, kind of one-offs really aren't fair. However, I would submit that they do highlight a certain excessiveness of something as silly as clicking a mouse, something that everyone who's listening on today's talk clearly, understands all too well. The actual doing of menial tasks in a modern electronic health record doesn't save time. And the number of clicks in order to sometimes complete some fairly simple tasks does seem needlessly excessive in many cases. Look, I mean, it's not that many things that we do in the electronic health record are hard. It's just lots of them are mind-numbing, right? I mean, and I think we can all sort of have examples of that. And that kind of leads to this introduction, or to this part of the talk that I want to talk about, information chaos. So, like, what is that? What do I mean by that? Well, I think we all sort of intuitively understand the concept of information overload, where there's just too much information to organize, synthesize, and draw conclusions or act on. And the electronic health record is certainly a potential for that. But there's also information underload, or the information is there somewhere but not accessible, or the clinician might not even be aware that it exists. So for all practical purposes, it really doesn't exist. So we can't access that. Then there is information scatter, and that's just information that's located in multiple places and is not always intuitive where that stuff is. Or information conflict. That relates to conflicting information in the health record that a clinician has no easy way to reconcile, and sometimes associated with erroneous information, so information that is incorrect, often perpetuated in the health record, that you can't get rid of very easily either. So you might assume that an electronic health record is actually ideally suited to address such cognitive burden. But let's keep in mind that there are few rules and conventions for engaging with the system. So think even, for example, of how we communicate with our multidisciplinary teams. Even in our own environments, we can have clinic notes that are routed to us. We can have private emailing within the system. We can use quick notes. We can, that become part of the text. We can be instant messaged. Like, we have all these mechanisms. Plus, of course, we can still get paged the old-fashioned way. The other thing we have to keep in mind is that there isn't a meaningful agreed upon curation of information, right? Like, even within my own nephrology group, we sort of struggle with, like, what are the important elements that we might be templating into things so that, one person can easily take over from the next person on a dialysis shift, for example. Let alone some basic conventions that are shared among hundreds or even thousands of clinicians. And then, of course, we can't really escape the fundamental issue that these systems were, by and large, not designed for integrated clinical care. And with that, let's keep in mind this sort of obvious, kind of elephant in the room, and that is that there are multiple ways to do many things in an electronic health record. And yet, it's sometimes surprising and even shocking how there are also very many examples of very precise and only one way to do many other things. And there are many illogical workflows that, could never have actually been designed by an actual user in some of these systems. And so these things are a little bit hard to reconcile. And I think it's helpful to draw on some of the work that's been done by human factors and ergonomics engineering. Now, this sort of is an area that I don't really know a whole lot about, so I'll assume that many of you don't either. So this area of science, social science, sort of the intersection of various sciences, looks at how systems, work processes, tools, technologies, and environments interact with the people who use those systems and processes. People who have cognitive limitations, physical limitations, and certain sets of abilities. And what they say, or what this sort of line of study would suggest about information chaos, is that information chaos leads to impaired situational awareness and increased mental workload. And so let's sort of look at that in a little bit more detail. If information chaos leads to these two things simultaneously lead to one another as well and are synergistic in their effects. So what do I mean by impaired situational awareness? So that means that we have to have an awareness and understanding of a task-related situation. So that means we have to have perception of cues from the environment. Now, that environment might include patient cues, like, is a patient distressed? What are the vital signs? What affect do they have? It could also be from lab data and from the written records. So those things need to be sort of perceived. There needs to be comprehension and integration of those cues. That means we have to be able to separate relevant from irrelevant information. And then we have to take all of that and project that into some sort of future state for decision making. So all of that depends on information and on quality information that can be either enhanced or impaired by the elements of information chaos, as I mentioned earlier. Now, at the same time, increased mental workload. So on the other side of sort of information chaos is increased mental workload that is a function of the demands that are placed on us and the available resources. And most oftentimes that resource is the resource of time, coupled with our ability or inability perhaps to cope. And so when you put these things together in the setting of massive information overload, we come to understand that this results in something called involuntary focus on fewer cues, or something that's dubbed cognitive tunneling. And part of the problem is, of course, is that this cognitive tunneling in the setting of information chaos is something that we are largely unaware of as it's happening. And so this guy, Richard Holden, who is an industrial engineer, psychologist, and human factors expert, has written quite extensively on the topic of cognitive burden, information chaos, and the electronic health records. And this study, again, just in the interest of time, I need to skip through this, but I'm just going to focus on the last panel here on the right in its comparison of paper versus electronic record. And I'm hoping that what you're going to see here is that this is not so much an issue of, a story that is black or white, a story that is, electronic health records are bad, paper records are good, that this is really a story of trade-offs. People really like the fact that the electronic health record is omnipresent and has lots of information immediately available. However, the trade-off is that information is oftentimes inaccessible, that there is a time and ease with which that is challenging in order to sort of extract that information. The electronic health record was deemed to be better at compiling, graphing, and searching, but the trade-off is that clinicians aren't able to sort of navigate and flip through charts and have that feel of knowing where things are at any given time, and be able to remove extraneous information. The electronic health record, while at one point is able to reduce fragmentation in charts, it increases fragmentation in other areas. And so the idea here really is that electronic records versus paper records, really result in or are a result of contrasting work processes, and that electronic health records have by and large offloaded a multitude of tasks onto physicians that were previously done by other people. And that was a very important outcome of this particular study. And so we can even think of some examples of, perhaps cognitive burden in our own worlds. I've listed some of mine here that just sort of represent that drip, drip, drip of aggravation. Think about blood work for patients with whom we have no clinical relationship. I get tons of this. Lab requisitions that materialize here in my printer for no explicable reason. Silly things like workarounds for dictating possessive nouns like Mrs. Smith's to get that apostrophe S. If anybody knows how to do that in a streamlined way, please email me afterwards because I'd love to know. Canceled orders that clutter my inbox, waiting for treatment plans to load. The number of cumulative minutes that we have to wait for dialysis treatment plans to load is mind-numbing. Dictation software that cuts out regularly, medication reconciliation that is truly abysmal, investigations that are canceled without the ordering physician being notified, trying to remember how to do complex procedures in the electronic health record that you don't do very often, so that each time you're learning it for the first time. Still not being able to consult with a general surgeon, even at our own hospital, transferring patients to non-connect care sites. Prescriptions that magically appear somewhere, even though they were never ordered. And this here, I think, is a personally striking example. See here I am, Robert Peter Pauly, and apparently this is a prescription for octreotide, injectable octreotide, a medication that I've never prescribed in my life, for an outpatient that showed up in a printer on one of the wards. And thankfully, a nurse paged me and said, here, you got to come and sign your prescription, that I had no idea about. In fact, I wasn't even in the province when this thing showed up. So God only knows, this is cognitive burden. However, in spite of all of these things, I too wouldn't want to go back to the old way. So that clearly the element of trade-off is an important thematic, that in spite all of the things that each of us have as aggravations, there are important elements that we just wouldn't trade. What I am curious about is, though, the relationship between electronic health records and clinician well-being, with the question that, does the electronic health record contribute to or detract from clinician wellness? Now, there's a ton of stuff written about this. Sort of the earliest of these studies really was something called the MIMO study, the Minimizing Error, Maximizing Outcome study, published in 2014, followed up in 2019 by this very important study from the American Medical Association, and then this one from 2021, a more contemporary study looking at burnout amongst clinical faculty and the clerical workload. Look, these are just three particularly large, more robustly done studies that I won't go to in any detail, except to say that time in the electronic health records associates with some sort of dissatisfaction and burnout, the extent to which is clearly arguable, and that EHR use outside of office hours is a particularly strong predictor of burnout. And again, I'm going to come back to that in a minute. Now, there's lots and lots of studies on this. I've just highlighted, in the previous slide, kind of three larger ones. This is another important study in this area, and I highlight this only because it's published by Tate Shenefeld, who at the time was at the Mayo Clinic and now is at the Wellness Center at Stanford, because this also represents sort of one of the larger studies in this area, entitled Relationship Between Clerical Burden and Characteristics of the Electronic Environment with Physician Burnout and Professional Satisfaction. And so what's shown here are the various workplace stressors, typical ones that are in this kind of literature: control over workload, the amount of teamwork, so the sense of team that you're in, time for documentation, the work atmosphere, whether your values are aligned with that of leadership, the time on the electronic medical record at home, and electronic medical record proficiency. And then here, this is the Maslow burnout inventory. This is sort of the gold standard for burnout, and the mini-Z, which is another one of these measures for burnout, very consistent results. What's important here is that these elements that I've highlighted here in red are elements that relate to the electronic health record and are, relatively significant in their odds for predicting burnout. Now, control over workload is the strongest predictor of burnout. What needs to be important here, though, is that the time for documentation, the use of the electronic health record, are just far more prevalent problems than control over workload in this particular study. So I think, therein is sort of something important that we need to understand. If you have no control over your workload, the likelihood of being burnt out is super high, except that that's just not as big of a problem perceived in this study as it is for the electronic health record. Now, I want to sort of shift our attention slightly from what I've talked about up until now, which is sort of the extrinsic burden of an electronic health record. That is, and to some extent, this relates to, the stuff we kind of had to do anyway, even before the electronic health record, because it relates to standard of practice and regulatory environments, to stuff that is more intrinsic, and that is the functionality of the system itself. And I find this sort of a fun thing to think about. And in order to orient us here, I want to introduce you to the idea of this thing called the System Usability Scale, or the SUS, which is an industry standard as a reliable measurement tool of technological usability with well-recognized benchmarks and an intuitive interpretation kind of across industries. So clearly it's a bit crude, but it is sort of a crude way to compare stuff. And you can see that a Google search scores 93. That's pretty easy. Using a microwave, only slightly harder, I guess. Ordering something on Amazon, starts to get a little more complex. Trying to do anything on Excel might be sort of more complicated. The SUS is, as it's adapted for an electronic health record, of course, it can be adapted really for any kind of technology, is really on this 5-point Likert scale that is eventually converted from positive and negative questions into a score out of 100, with questions like, I like to use my EHR, or I find my EHR unnecessarily complex, all the way down to, I feel confident using my EHR, I feel my EHR is very cumbersome, I needed to learn a lot of things before I could get going in my EHR. So you sort of get the idea of kind of what this is driving at. And you can see that the mean SUS score among, I think this was about 1,000 US clinicians, again, from the Alberta, not Alberta Medical, but rather from the American Medical Association, was a score of 46. And, where that falls here is that falls kind of, way off the end of the spectrum, kind of in the lower 10th percentile of kind of all things relating to kind of, general technology. 84% of American physicians rated their SUS score below the industry average of 68. So, this is sort of where everything just sort of tends to fall. So what's interesting is that, with sort of multiple regression analyses accounting for a whole bunch of other stuff that might be able to predict burnout, SUS scores remain predictive, whereby 1 point increase in the SUS associates with a 3% lower odds of burnout. Now, that has to be balanced because that sounds like it's a lot, but the proportion of variation in that Maslow burnout score that's actually explained by the SUS score is only about 6%. So one could argue, perhaps, is 6% a lot of explanation for burnout, or is it just a little bit? And one could probably argue that in several different ways. Now, I guess, I want to leave you with, sort of a few considerations around this particular topic. One is that much of the data that I've shown you is a global assessment of electronic health records across, different systems, different physicians, different specialties. And so these things shouldn't be viewed as an indictment of a particular electronic health record. I've put this figure here up just to show you, though, that when you do look at these things in aggregate, Epic Systems does represent a fairly significant proportion of electronic health records in American use. And so, like, for example, it makes up about 1 in 4 health records that are used in ambulatory care settings, and about 1 in 10 within hospital settings in the United States in about 2018. So, clearly, much of what I've shown you does reflect Epic Systems in some capacity. The other thing that's important to recognize is that there is a causation predicament. And what I mean here is that, does the electronic health record cause burnout, or do burnt out clinicians simply hate their electronic health record? And I think that's a fair question to ask. However, one does need to sort of reflect on the fact that there are clinician groups who in general are quite happy with electronic health records. So thinking specifically emergency room physicians who tend to actually be more pro-electronic health records, who at the same time have very high rates of burnout. And then, so clearly there is sort of not this very clear relationship between these two. There's also what I would say is conflation potential, and that is blaming the means to an end rather than the end itself. What I mean here is that if there is the burden of some sort of documentation, if there are requirements to do shadow billing within the electronic health record, if there are elements that we have to do now that we used to offload onto our secretarial staff, but now as clinicians we're faced doing those things, that's really not a problem with the electronic health record. That has to do with how these things have been implemented, and how we are asked to use them, not necessarily a problem with the EHR themselves. The other thing is that this literature is really based around user silos. And what I've shown you relies solely on physician perspectives and doesn't take into account perspective of other members of the healthcare team, nor that of the patient. And we can't forget that there is this question of system familiarity at the time of assessment. If someone had assessed me at the time, like say in January of 2020, I would have had a very different relationship to the electronic health record as I do in January 2022. And then, of course, there is the potential of publication bias. How likely are studies that contradict the EHR causes burnout narrative to be published? Although perhaps there is a counter bias as well. It's hard to know. Where do we go from here? Where does the medical community go from here? And I think, I'd like to kind of think about this in terms of an interventional matrix. And what I've listed here are kind of the stakeholders across the top. That's industry, regulators, hospital systems. Now we get into clinical groups and individuals. This would be the areas over on this side of the screen where we might actually have some impact within our own, sort of sphere of influence and sphere of control. And then down this axis, we've got kind of the areas within the electronic health record that sort of pose potential areas where we might want to be looking for fixes. And, here are sort of some general principles that I guess, we could be thinking about. Improving the IT itself. I mean, that's probably beyond our control. That sort of falls in the sort of the industry category. But we could improve how we use the technology and the rules of engagement. That really does fall within our purview, and it means that we need to engage with one another to come up with some rules of engagement. I think importantly, and this is, I think, is really important for medical leadership to understand, is that we need to make space in our job descriptions for known inefficiencies within the electronic health record. And so, if it took a certain amount of time to see patients or do certain tasks, and now it takes more, we shouldn't be expected to do the same in the same amount of time if we have to use this process. And then, of course, leveraging QI processes to see if we make changes, does it make a difference to things that we actually care about? So with that, as I just quickly want to recap, I have described for you the historical context in which there was electronic health record spread and scale. And I hope that you're understanding, perhaps why we have some of these glitchy systems that exist, that happen in a very specific context. I described how electronic health records impact some elements of care delivery, thinking about clinician time, clinician interaction with the patient, and then this very important topic of clinician microaggression and cognitive burden. And we've explored some of the relationship between the electronic health record and clinician well-being, and have really come to understand that it's probably more an issue of trade-offs versus, sort of a clear-cut, problem versus not problem. And with that, I want to thank you very much for your attention. I'll invite whatever questions we have in the tiny amount of time I think we might have left. And you can always email me as well. So thanks very much.
That was excellent, Rob. Really nice overview. And I know you really kept it sort of evidence informed. But one of the questions that has come up repeatedly and that I was wondering about as well is, you really do wonder with proficiency, how much of this stands the test of time. As you said, last January, we were all still sort of in this, or January 2020, we were still in this frustration mode. And I know that, things have improved. And so are there any tips or recommendations you have related to that, in terms of what the literature says, how to develop those tools, I guess, to make it easier?
Yeah, it's a great question that I guess I don't have, terribly robust answer for. I think what people talk about a lot are kind of what we've done in our system, to have kind of electronic health record champions who need to continue to remain engaged. And what I worry about, and I think this is my own experience personally, is that everybody was very full on engaged at the very beginning. And now we've come up with lots of workarounds in our own little private worlds that, it probably is helpful to come back to some of our electronic health record champions and kind of itemize, okay, you know what, now that we're pretty proficient at things, like, can we start categorizing like the top 10 things that just aggravate the crap out of us? And is there something that we can do within our purview that we can do to fix some of those things? And I think what that means is that we need to have some thoughtful engagement on an iterative basis. And I think that's where clinical groups can both leverage the experience that they have, because lots of people have discovered cool things. And it's amazing how even now, like a colleague down the hall will tell me something that I start to use the following week. And like, I feel like things have changed. And someone else has been doing that for a year already. And it's the fact that, I remember in the early months of Connect Care, our own group kind of met like literally every week, then every 2 weeks, where we shared stuff. And now, we seem to have fallen off, and our own nephrology group is starting to redo that again. And I would encourage other groups to do that again, so that we start to pick up again to increase that proficiency. Some of that is evidence-based. A lot of that is just me spouting off.
Well, it's really interesting. We had this group of super users identified at the start, and I'm sure you found this in your group as well. Suddenly, new super users emerged who clearly were very proficient, and now they're giving us the tips, right? So yeah, I think that's really important to keep coming back. Of course, a small thing called the pandemic got in the way in terms of some of these initiatives that we had in mind. But there was a New England article a few years ago that talked about going to the front line and identifying what those niggly things are, and you know, sort of going at those.
Yeah, I mean, I think it was called getting rid of stupid stuff.
Right. So of course, I know Stan was asking about the patient perspective, but this rounds was really around the physician burnout perspective. So I get that. Lastly, Quentin asked about whether or not there is any data on gender perspective. He wondered if maybe that pajama phenomenon is more common amongst women as opposed to men.
So it is, and you know what, Quentin, I apologize for not mentioning that. It was in one of my speaker notes, and you know, when I give a talk, I don't always go back to my speaker notes. You're absolutely right. That pajama time is, and the pajama time and or inbox time, I can't remember which one of those two studies this referred to. There is a disproportionate effect on women. There's a disproportionate effect on clinicians who see women. And there was one other element that escapes me, but that was very clearly gendered. And so there is sort of a little wedge of this literature that would suggest that there are different practice patterns between men and women, which I don't think is going to surprise many people, and that the electronic health record and that the burden of the electronic health record is disproportionate on women versus men. Now, look, I mean, I can't speak to the robustness of that data, but there is definitely a signal, and I appreciate, Quentin, for you bringing that up.
I can say, as a mother of former little ones, they're older now, but you know, it would have been nice to have the flexibility too, though, right? So there, as you say, there's always the counter argument towards, you know, you need to shut off, but also there's now this level of flexibility that, you know, with the paper record that we never had. So
yeah,
we have come to.
Oh, sorry. Yeah, I mean, I guess I just want to sort of finish by saying, look, there's going to be haters and there's going to be lovers. And you're never probably going to be able to reconcile those two. And somewhere in the middle is sort of the thoughtful trade-off analysis. And I think that's probably where we need to try to get to, even if we think about these things academically.
Yeah. Rob has kindly agreed to look at the rest of the questions, and we've also put his email address in the chat box. So on behalf of the department, thank you, Rob. I just wanted to let people know that next week we're actually going to do a grand rounds just on how to run a COVID ward, because we know we are asking more and more people to run a COVID ward. So that's next week. And then the week after, we actually have our 3ID docs doing a COVID update. So we are going to shift focus a little bit onto COVID just in a timely manner. Thanks, everybody. Have a wonderful week and stay safe.